alaikum, good evening and good morning to everyone they are listening to us wherever you are. I would like to welcome our eminent and esteemed speakers. I'm proud today to have really an eminent speaker from everywhere from the world. We are having a very eminent speaker from India that representing Asia, if she allow me to say that. We are having also speakers from the regional area, local area, Middle East, and we have from United States of America. Welcome all. And I will just introduce all the speaker once so that we can have a time then for the presentation without interruptions. Um, with panelists here, we are having Dr. Yahya Salahuddin, is a well-known figure, professor of ophthalmology, Cairo University, chairman of Eye Care Center, cataract, cornea, and refractive surgeon consultant. We know him, Dr. Yahya, for a long time, and he is one of eminent speaker in the Middle East and worldwide as a cataract and refractive surgeon. Also in panelist, Dr. Safwan Al-Bayati, my dear friend. He's a fellowship of Royal College of Physician and Surgeon of Glasgow, owner and medical director of New Vision Eye Center in Dubai. He's a phaco, refractive, and vitreoretinal surgeon. And Dr. Safwan, also a well-known figure here in our area, Middle East, and worldwide, especially in the refractive surgery. Also, I'm proud also to have today from Jordan, dear friends, Dr. Amal Warikat. She is an MD, FRCS Glasgow. She is a cornea and refractive surgeon consultant, Royal Medical Service, King Hussein Medical Center, Amman, Jordan. Welcome to all panelists. They are going to be with me in moderating and discussing these sessions. For speakers, we'll have the first speaker, Dr. Muhammad Imad Alilo. Dear friend, he's a specialist ophthalmologist in Medcare Hospital, Sharjah, and he's a cataract and refractive surgeon, and he is well known also figures in United Arab Emirates and also in the Middle East, and he is deliver a lot of talks in his specialty. Also today, it's my pleasure and honor also to introduce and to have Dr. Narmata Sharma, Professor of Ophthalmology, MD and DNB, MNAMS. She is a cornea, cataract, and refractive surgery service. She is also in Dr. Rajendarar Prasad Center for Ophthalmology Science, All India Institute of Medical Science. Dr. Narmata, she is having a lot of publications, as I do remember, maybe around 450 publications. She is also have many national and international awarded for, I cannot now count it, I read her. It was an amazing and actually an honor and pleasure to be with us, Dr. Narmata.
Thank you.
Also, it's my pleasure to introduce my friends, Dr. Yasin Dawood, Chair of Ophthalmology, Howard County General Hospital, Associate Professor of Ophthalmology. Also, Dr. Yasin, also our known figure in cataract and refractive surgery. And also, pleasure to introduce one of the main figures in ophthalmology, also Dr. Zaina Al-Muhtasab, MD, Associated Professor of Ophthalmology Department, Baylor College of Medicine, USA. Not last, also before, also the last one, Dr. Ahmed Al-Barqi. He is an MD, FRCS Ophthalmology Consultant, Vitreoretinal Surgeon, Sheikh Khalifa Medical City, Abu Dhabi, UAE. And lastly, my dear friend from Saudi Arabia, Dr. Saad Wahib, Associated Professor of Ophthalmology, King Abdul Aziz University College of Medicine, KSA, Head Section of Ophthalmology in King Faisal Specialist Hospital and Research Center in Jeddah, KSM. Thank you for all of you for being with us. And really, it's amazing. And I mean, it will be a very high level of scientific program with your presence. Highly appreciated for being with us and accepting our invitations. So I will start now with the first speakers, my dear friend, Dr. Imad Alilo. He's going to talk about ocular surface disease between facts and myths. Dr. Imad, the mic with you, please.
Thank you, Dr. Muhammad, for the nice introduction. I'm gonna share screen now, if you don't mind.
Can I ask all the speakers, please, to be mute so they can allow the without?
Ladies and gentlemen, dear colleagues and friends, good evening. Tonight, we will talk, we will go in a little journey around the ocular surface world. This fascinating world, it's a good example of what Einstein once said. Not everything that can be counted counts, and not everything that counts can be counted. This simple truth, if we want to think about it, we can see that it is perfectly matched the ocular surface physiology, because it's really a complicated environment when you have a lot of factors that you don't understand it perfectly, but it works together to give you a different results in each case. My curiosity about that started long back in 2007, 2008, when I done my ocular surface or cornea program in the Orbis Flying Hospital. I was working with Professor Woodford Van Meter and Professor Pasik at that days, and I was really surprised how people act differently after keratoplasty. Some cases you can see next day crystal clear cornea. The others, it takes a long time to recover and extended healing. This arose my curiosity and give me a passion. That passion took me far away to Nottingham University in 2010, when I have joined an extensive course with Professor Dua in this very experienced or very specialized center, when you have referrals from all over UK and sometimes from Europe as well. When you can sit beside Professor Dua and see all of these kind of cases and see how he had to analyze every case separately and acts. Then I realized it is not a simple or straightforward thing. It's a complicated world, actually, when you have a lot of factors to work as an orchestra in one harmony in order to have the good performance. And slowly in the last few years, we start to understand that there is a mechanism for orchestrating the homeostasis among tear production, corneal nerves, immune cells, corneal and liberal stem cells, and the eyelid margins in terms of structure and function. So this multifactorial system led to more understanding that there is so many factors interfering, neural, vascular, hormonal, and immuno system. So recently we understand more and more the role of inflammation in the ocular surface problem, especially the dry eye, when we have this viscous circle, which when each aspect are enhancing the other one. So any one of us can suddenly, whether for intrinsic factor or extrinsic factor, can slide in this viscous circle, and we need to understand which is the pathology in each case and direct our treatment or management toward it in order to have a very good result. So we are now understanding that it's not only on the ocular surface, it goes beyond the ocular surface to the other parts of the immune system, like lymph nodes and even spleen. So now we all have almost a consensus that there is a kind of tear film osmolarity change, lead to tear film instability, loss of homeostasis, disrupt of the ocular surface barriers, and lose of the corneal epithelium as apoptosis. And we are understanding the new role of these new receptors like ICAM1. So when you look at the hat from three different aspects, you will get three different points of view. And clinically, this is what is going on now. Because right now, when you look to the ocular surface disease as a general, you have three approaches, I would say. The first one is the standard one. This is the DOS2 approach, which go to the majority of the cases. Among this, we have also the more focused approach, which is the American Academy point of care principles. And if we look more widely, we will go to the wider circle which is explained by the Cornea and External Disease Society. We will have a quick look for each one of them and how they are dealing with the cases. For algorithm one, let's say the DOS2 treatment, we all know the 3 or 4 levels of treatment, which we go classically when we have to address each single factor in each case and try to direct our treatment to the defected area in order to sort out the problem. For example, this straightforward case, she is a female, 57-year-old. She having some itching, redness, foreign body sensation. There is no history of medication or skin disorders and no history of office work. She have a normal blink rate. So just one of the common cases when you can see the hyperemia of the lid margins, you can see the moderate MGD, and you can start, in this case, we have started standard treatment toward blepharitis. So in the second visit, MGD improved, but there is very mild improvement in the symptoms. So we added Liposic. We decided finally, when we see that the standard treatment is not enough, to escalate and go for cyclosporine A along with lubricant, and we can see how finally the case respond and the Schirmer test went back to normality and the eye looks back. So this approach is quite useful and straightforward case, but it is not enough when things come to very sensitive cases like people who are candidates for cornea and refractive surgery. When we need to meet the high expectation of those patients by fixing the ocular surface prior to the surgery in order to guarantee that we are having a perfect measurement for our patient. So a lot of armamentarium, new things has been introduced, like the questionnaires, the tear lab, the inflammatory markers like MBB9, the ocular surface analyzer, and this concept depends on initial evaluation for the ocular surface. If it is okay, we can proceed for our measurement. If not, we need to give a proper treatment to improve the ocular surface prior to before proceeding for our surgery. This is an example of such cases when I have a case of 62-year-old who have, he's coming for a cataract candidate. He's a glaucomatous patient on Travatan. He was using it for a long time. So you can see that the ocular surface, the conjunctiva is very congested. The cornea has SPK, very poor tear film. Tear breakup time is around 8 seconds, and the osmolarity is really high, 325. So in this case, we decided to go to manage that by changing from Travatan to Saflotan, decrease the preservative-free, decrease the preservative effect on the ocular surface. We add some steroids. We used a good lubricant, extended one like iCross, and added Restasis. After 3 months of treatment, we can see that the ocular surface improved, corneal SPK disappeared, tear breakup time improved, osmolarity almost come back to normality. Then we proceeded for the surgery. So this is a very important point. We need to take care of it in order to guarantee a good results. Now, we all know that one more important aspect, which it is new comes to the market, is the lubricants portfolio. We have now very huge portfolio of the lubricant, which is added to be our armamentarium. One of the new player is the iCross 0.4. It is a cross-linked hyaluronic acid. This interesting concept means that when we cross-link the hyaluronic acid, sodium hyaluronate, we have two kinds of new connections, the intramolecular cross-linking and the intermolecular cross-linking. This unique structures gives more stability on the ocular surface, and it is having special resistance to hyaluronidase, which usually fragment the hyaluronic acid and prevent its effect anymore. So we can have some extended effect on the ocular surface, and that was proven when we measure the surface asymmetry index and the surface regularity index in one study using the pentacam, and it proven that comparing that new modified structure with the standard lubricant, it gives more effect because it lasts longer in the ocular surface. So this new player in this field can give us more stability and accelerates the corneal epithelium healing. It's just one of the new factors which we are having it and can help us in managing our cases. When we go to the wider, when we go a little bit far and look to the wider scope of the ocular surface disease, we come to the unique approach of Cornea External Disease and Refractive Society, which has stated the dysfunction tear syndrome concept. Where there is a multifactorial, which is started, of course, in 2017, it's a multifactorial etiology with overlapping between etiology. This approach is more realistic because it's mixed. It is not something standard, which is the same as the control trial, which you can eliminate whatever you want. No, this one is trying to deal with the real world, with the variety of cases, and admit that there is mixing of factors which lead to the pathology we are seeing. So, and the unique point in this algorithm is it's stated the management in a step ladder manner. So the management depending on step-by-step strategy, like as we deal with glaucoma, and it also includes the using the wide variety of medications and even procedures, which some of them are off labels sometimes, to achieve our goal. So this approach, dysfunction tear film, has classified the dry eye into aqueous deficiency, blepharitis, evaporative from goblet cells or murine deficiency, and exposure keratopathy. And it's introduced a new concept, which is the co-conspirators. This is a kind of pathology which mimic dysfunction tear syndrome, but it has its own pathophysiology, like allergic keratoconjunctivitis, like superior limbic keratoconjunctivitis, conjunctival chalasis, thixins, and even the effect of medicamentosa, which we all know its effect on the ocular surface. If we want to use this approach, we can look at this case. 25-year-old female, very young and active. She came, she's working 8 to 10 hours in an office job. She came with pain, redness, blurred vision in both eyes due to her extended use of contact lens. She was using it for more than 10 years now. When you look to the cornea, you can see this unique shape of ground glass cornea. You can see that the periphery has a lot of panels. The center, when you have this shape of SPK and ground glass appearance, the vision deteriorated in the right eye to 624, in the left eye to 612. Now, when you look carefully to the cornea, you realize that there is, beside the panels, there is 2 different types of epithelium in this cornea. You can understand that the extended usage of contact lens has destroyed the barrier of the stem cells and facilitated a kind of conjunctivization of the cornea by letting the conjunctival epithelium slide over the cornea. So in this case, when you want to manage it, you have 2 approaches, the conservative one and the invasive one. I decided to mix and match. In the right eye, when the cornea or this conjunctival epithelium was even covering the center, I decided to do what we call sequential SEECT, sequential. We removed the corneal epithelium in the center. We removed all the conjunctival epithelium until we reached to the normal corneal epithelium, and we allowed that corneal surface to heal under the cover of Vigamox. While in the other eye, in the left eye, I decided to go for medical management depending on Lotemax and lubricant. And this is the right eye. When we do the scrapping, you can see that in the second day it starts to heal. And after a few days, the right eye has completely healed with very good shiny ocular surface. The left eye, because we did not intervene vigorously, it improves, but it was a little bit slow. So This is the final case when you can see that the right eye is quite crystal clear and the left eye is in a good condition. This kind of cases show us how there is multi-factors interferes in reaching to the certain pathology. This is another case of almost 30-year-old female who come to the clinic complaining of decreased vision. She had a smile surgery back in October 2016, and her previous refraction was just a mild refraction, minus 2.5. When you look carefully, you can see that in the right eye, there was a certain area of scarring and edema next to the vertical wound when we go usually and extract the lenticule. The best-corrected vision was 612, 618. Pressure was normal, refraction was almost normal, but still she cannot see properly. So if we look carefully to the corneal topography, we can see that suspicious elevation in the posterior and in the anterior and posterior corneal surface in the right eye. And you can see that the D is almost high. In the left eye, you can see almost similar picture, which give you think of having, is it an ectasia post-refractive surgery, or what is going on in this cornea? So I requested the preoperative topography and was suggesting of farfurous keratoconus, so it was highly suspicious of possible ectasia, but the decision was to continue conservative treatment and the golden rule, wait and see. After 10 weeks, it starts to improve a little bit and scars to settle down. When we look to the topography, we can see it's improves slightly. It is not that quite great improvement, but suddenly what happened is it's improved up to 6.9 and with mild correction to 6.12. And you can see how much the topography has been changed without any serious intervention. It is only the medical treatment there. So I cannot explain this case simply, because when you have a suspicious cornea and suddenly it turned back to its normal stable, then you think that maybe the keratocytes has played some ununderstandable role in this case. So the final case, I'm gonna finish with it. She's a female, 12-year-old. She come with decreased vision in the right eye. She was diagnosed with corneal ulcer and hammered with so many type of antibiotic till it comes with this awful neovascularization, reach the optical center and drop the vision to almost 660. So at presentation, that was the situation. When I analyzed the case, the key diagnosis point was she has an intact corneal epithelium, she has decreased corneal sensation, and there was a negative corneal swab. So I decided to go and consider it as a herpetic stromal keratitis with proper management of steroids and lubricant and the coverage of acyclovir. It was amazingly improved. And finally, after 2 weeks only, vision went back to 0.8. And of course, she needs further management for this residual new vessels. This variety of cases give us an idea about the complicated etiology which is interferes in the pathophysiology of the ocular surface disease. We now have different algorithms. We need to use them wisely in managing case-by-case cases. And we have also new tools in our armamentarium which help us in tackling these cases, like the new immune modulators or the better and advanced formula of lubricants like the cross-linked hyaluronate. Clinical management is an art rather than a science. Thank you very much.
Thank you very much, Dr. Imad, for this an excellent presentation. Is there any question from our panelists to Dr. Imad? Yes, Dr. Safwan, first, please. Yes. You are mute. You are mute, Dr. Safwan. Unmute yourself. Yeah.
I'm sorry. Dr. Muhammad was excellent presentation. Only two comments that I need to add is that the use of Tobradex for the marginal congestions and marginal myomyitis, and the use of soflaton instead of travatan in an inflamed eye. So, in my opinion, that Tobradex is an broad. It's not a broad spectrum, and it's bacteriostatic, not bactericidal, and it has a very high rate of allergy to tobramycin. So, my advice is that Tobradex is not the ideal treatment here. And the prostaglandin analog, when you have it and you have this inflammation in the ocular surface, changing it to soflaton just to prevent or to reduce the effect of the preservative is not the key here, because soflaton by itself, the travatan by itself as a prostaglandin, it's creating a lot of intraocular inflammation, and this patient prepared for the cataract. So post-op, he will continue on prostaglandin, and that's one of the causes of the pseudophakic cystic macular changes. Great, thanks.
Dr. Safwan, okay. Dr. Imad, you have a comment, but very fast, please, because we are over the time, please.
Thank you for your wise comments. The point is that the patient has a medicamentosa reaction. I have to go for some kind of treatment which does not have preservative. Unfortunately, we don't have so much options when it comes to preservative-free glaucoma medication available in the market.
We have now COSOP. We have COSOP now, and sooner we will have a few medications that will be preserved. Now COSOP preservative-free. Yes.
Yeah, that's nice to hear.
Yeah. Also, I think Dr. Safwan, soflaton is preservative-free.
Yes, my dear. I'm talking about prostaglandin analog, because the effect, the inflammatory process coming from the prostaglandin analog. So soflaton prostaglandin analog, Dr. Muhammad.
Yes, okay. But so, just one point, it was a medicamentosa reaction, Dr. Safwan. We need to eliminate that. Regarding Tobradex, I wanted to use dexamethasone because Lotimax was not effective enough, and we don't have in the market also. If I have a preservative-free dexamethasone, I will be more than happy to use it. Use for the dexamethasone rather than the tobramycin.
Yes. Okay, thank you very much, Dr. Imad. Thank you, Dr. Safwan, for this comment, and excellent also Dr. Imad presentation. Stay with us. You will be also in discussion involved about the episode of Cataract 5. We are going to talk about the complication of phacoemulsification, prevention and management. And our first speaker, it will be Dr. Narmata Sharma, and she is going to talk about phacoemulsification wound-related complications. Dr. Narmata, the mic with you, please.
Thank you, Dr. Amri. At the outset, I would like to thank the organizers of this Middle East Ophthalmology Symposium for making me a part of this. I'm truly honored, and it's a pleasure to be here with you all today. Would particularly like to thank Dr. Amri for coordinating and
it's our pleasure and honor, Doctora.
Thank you so much. So I would come to the topic of my presentation, and that is wound-related complications in phacoemulsification. And there are no financial disclosures, although I would be talking about intraoppository microscope, which you don't require for it, but it just helps me to explain the wound-related complications better. That is the advantage that, how I see. I would be discussing about the incision constriction, the construction, the iris-related problems, the Descemet's membrane detachment that can occur, the femto-incision complications, as well as the wound leaks. So now coming to this one, this is an uncooperative patient who's being done under topical anesthesia, and notice how the surgeon makes a little ragged incision, and it is on to the little more to the left side rather than being on the right side. So it's an irregularly shaped funnel. It is neither rectangular or square as it should be, and as is classically described. So it is possible to do phaco, but what would happen is that you would have to distort your wound, and with the help of the second instrument, because you need to get that thing into your line of action, a wound will have to be always moved towards the right side. And this may cause a little bit of distortion also, just like in this case. So the model of the story is that the main incision should be at temporal 1 or 2 clock hours rightward if you're a right-handed surgeon, and never go to the left of the temporal midline, and the shape of the funnel should be either square or should be rectangular. Now, there can be problems with the improper incision, which could be unstable anterior chamber due to wound leaks, undue resistance in the moving phaco probe. Such wounds are more prone to Descemet's membrane detachment, And of course, torsion of the globe can occur while performing surgery due to poor ergonomic position of the handpiece. Now, you can have cases in which there is iris prolapse, which can occur, especially if your incision is a little more limble or if it is a short tunnel. And in this case, while doing the hydration of the wound, again, one has to be careful where exactly you're doing the hydration, because if you put too much of fluid inside while doing the hydration, which actually goes into the anterior chamber, and is not hydrating, then in that case, the iris prolapse can occur, as it occurred in this case. So the needle where it was going, the cannula, the hydration was not done at the proper plane. An important thing is to just put the iris back, which could be done with the help of the iris cannula or with the help of the spatula, and then hydrate at a level which is little bit anterior as compared to what was being done earlier. Now, at the wound site, sometimes you can have these little DMDs, and again, these are visible only on the intraoppository microscope, but won't be visible otherwise. But if you do happen to see them, then it is best to address them. You can put a little bit of air bubble there so that the desmoid membrane gets attached. And even when you hydrate the wound, actually the stromal hydrated part, it gets abutted to the detached portion of the desmoid membrane, and also the gap is filled up. Now, this is yet another case in which phacoemulsification was being done, and after completing, it's a short tunnel, inadvertently a limbal incision. So when you do irrigation aspiration, there is, with withdrawal of the instrument, there is an iris prolapse. Now, there are two ways of managing such cases. You can put it with the help of the spatula back and then continue to do your bimanual irrigation aspiration, or that ideal would have been that, and then the iris is gently nudged back into the anterior chamber as the surgery proceeds. And it is best in this case, as was done, to put the intraocular lens and again hydrate the wounds. You can also put pilocarpine, because then the iris would move away from the wound site as the pupil constricts. So iris prolapse can be because of the incision which you've extended, or because of posteriorly placed incision, which is going too limbal, or because of the short tunnel, so that there's premature entry into the anterior chamber. Even if you do a OVD overfill, it can lead to iris prolapse, and overzealous wound hydration can also cause iris prolapse. So also can misdirected flow of the fluid cannula, as was seen in one of the cases, because eddy currents will be generated so that there's sudden increase in the pressure under the iris, and the iris prolapse occurs. So whenever there is an iris prolapse before the nucleus management is complete, mostly occurs because of the OVD, and it is important that you purge the excess of the OVD, because OVD itself can force the iris to come out. So reposit the iris with a blunt spatula, press the posterior lip to purge more of OVD, and insert the phacoprobe with the irrigation off, and maneuver beyond the pupillary margin, and then press the irrigation pedal, and then complete surgery with minimum exchanges. And of course, if there is too much of a problem, then you can even abandon the incision and suture and create a new main incision. However, if it occurs after the nucleus management is complete, like we saw after complete IA without touching the prolapsed iris, then you reposit the part of the iris, underfill the bag with the OVD, do the bag implantation, and hydrate the main incision very gently. And again, inject pilocarpine and air bubble if required. Now, apart from this, from the wound site itself, there can be desmoid membrane detachment, like it occurred in this case. We did a study and we found that the wound sites may have desmoid membrane detachment, but almost all of them would get attached at post-op week 1, if not at post-op day 1. And there are very few which will not get attached. You can see here in this case at the wound site, this tells you the intersection of the area of focus. At the wound site, there's this little small desmoid membrane detachment which is there. And when you do hydrate, actually, this spindle will come and abut this desmoid membrane. So partly it will be taken care of, and if it is not taken care of, then from the side port you can put a little bit of air and then again see that it is getting attached, and the desmoid membrane is neither folded nor wrinkled because of the fact that it is attached at the wound site. And this is something that one needs to prevent. Then this is a case of pseudo exfoliation in which there is a Descemet's membrane detachment, and also notice there is some wound burn because this was a hard cataract, a small pupil. And as we are putting viscoelastic, you can make out by that bluish reflex that this DMD is increasing. And now, because this has to be taken out, so you have to do it from the main wound only. But notice that there is this small DMD which is present here, which can be seen. So whenever this occurs, it is important that from the side port you put some amount of viscoat so that it causes the apposition of the Descemet's membrane at the wound site to the back of the cornea. And once you do that, then your maneuvers can be undertaken because viscoat will cause complete apposition. But of course, when it starts to come out, then it may have to be refilled again. Now, again, it's very tricky when you have a DMD to inject to implant the intraocular lens. But even if you've done that, it is again important that you put an air bubble and you see that the Descemet's membrane is attached. And then in such cases, it is best not to hydrate the wound because the DMD went almost till the upper pupillary margin. Best to suture it, and you can even take full thickness suture so that you take the Descemet's membrane along with it. And this is done with the 10-0 monofilament nylon suture. So these I have essentially the do's and the don'ts I have already told you. Whenever there's a wound site Descemet's membrane detachment, don't attempt a wound assisted IOL injection, but it is best to go a little bit inside and then inject because you don't want the edge of the lens hitting on the detached Descemet's membrane and causing the rip to further extend. Then apart from that, there can be leaking incisions, such as in this case, this is a posterior polar cataract, and all leaks have to be determined. And in this case, phacoemulsification was done, followed by a foldable intraocular lens implantation. And just as you do this, you notice this little area is still blackish in color. And there is a leak which is present, which you can make out because your air bubble will keep expanding. So as you hydrate the wound, the main incision leak now at this point in time here is noted. And as you hydrate the wound, the bubble, which was small earlier, will start to become bigger. And then you know that there is a leak there. That will happen only if there is a wound leak there. Notice how this small bubble, which is present here as you hydrate, will tend to become bigger because of the presence of the leak. And there are various ways of, again, diagnosing the leaks. You can put fluorescein dye to stain that there's a leak or not. People have even described the use of trypan blue dye to see whether there is a leak or not. And this is a third attempt at hydrating and still it is not getting hydrated. So then it is best not to let your ego come in between and to suture such wounds so that there is no wound leak present because you don't want complications of wound leak and thereafter. Now this is just to show you Descemet's membrane detachment which can occur during the again a wound site detachment which has occurred here, which you can see very well, which is present here. So in all such cases, it is best to pilocarponize the pupil and put the air bubble, and then you will see that because of the hydration and also because of the fact that this air bubble is there, it gets pretty much attached. Now, there can be, this is just a post-op day one picture of how a phaco-incision wound detachment has occurred and it had led to so much of corneal edema. So you pilocarponize the pupil and again go from the area which is relatively clear. And as you do this, the Descemet's membrane is quite attached, but not so much. So you may have to do some external massage also in these cases to get the Descemet's membrane to attach. And especially from the wound areas, it becomes a little difficult because the air keeps leaking from the wound area also, which is fresh. Now, this is the last clip to show there can be problems with femto incisions as well. The femto incision is not opening here. And when you look at the intraopacity microscope, you'll see that there's a bridge which is present posteriorly, not anteriorly, and that has to be taken care of. And like classically, it has been decided that you can put trypan blue dye and actually see whether the dye is going inside or not, and whether where is your incision on the IOCT. If you see, trypan blue does help to delineate the edge, which sometimes becomes difficult with the femtophaco wounds. And you can see that this bridge is attached posteriorly, but not anteriorly. It is quite, it's quite open. So such cases, one can again use the keratome to open that posterior bridge, and subsequently can the same problem with the side port also. It's not opening up, and then here sharp blade is used to just open that little area of the bridge which is there, and the tunnel of the incision is already present, so you really don't have to do anything much. So I think I've already explained. If femto incision is not possible, it is always better to abandon the femto incision and make a fresh incision with the keratome. So these were the clips of the wound-related problems. At times, there can be also chemosis, which occurs mainly because there's a conjunctival disinsertion which has occurred at the side port of the main wound, and then one has to give nicks in the conjunctiva and eject out the fluid. So thank you for your kind attention, and I would be very happy to take any questions that are there. Wound construction is, I think, extremely important because due to small mistakes and due to problems in the wounds, if they are not addressed timely, then it can really get very difficult.
Thank you very much, Dr. Narmata. It's very excellent talk. Actually, you cover most of the points that we need to hear about it in a very nice way. There will be a little, maybe some questions and comments. Let me ask Dr. Yahya Salah if you have any comments, please, Dr. Yahya, if you are with us.
Thank you, Dr. Sharma. Excellent presentation, covered everything. I just have comments for our junior colleagues. One of the problems is the rounding of the wound. So it makes it difficult to close if the wound is smaller and the surgeon tries to fit in the phaco probe and continues the surgery. And this could also lead to the wound burn. So avoid rounding the wound so as to be easier to close. Also, just a small comment, in iris prolapse, it's usually easier for the surgeon to reposit from the paracentesis.
Yeah.
So,
thank you, Dr.
thank
Yahya.
you, Dr.
Okay,
Sharma, for excellent coverage.
Thank you. Thank you.
I have one question to Dr. Safwan. Dr. Safwan, suppose we didn't notice there is a cement membrane detachment during the surgery, and we found it in the next day, for example, when we are just following the patient. What is the solution you are going to do? Dr. Safwan, you are mute. Can you please unmute yourself? And as fast as
Muhammad,
possible.
as Dr. Sharma presented in an excellent way, that most of the cases we are seeing it in if you are allow me for the second case, just to share a few things. If you stop the sharing, Dr. Yasin, please, if you don't stop sharing, I will show you. Most of our cases, we are taking it and see it through the intraoperatively, except when we are suddenly surprised that we have second day.
Can we do it fast, Dr. Safwan?
Yeah,
We say we need only within 30 seconds, please.
Yeah, I'm trying.
If not, we can keep it to the end if you are still going.
No, I'm just trying.
Okay, Dr. Safwan, we can move to Dr. Just we keep this one. You will share it with us. Can you give it with talk? Then later on, you can show it at the end.
Okay. The issue is the important point is that when we are retry to implant the Descemet's membrane, that we are saying, first of all, the second day when we have corneal edema, we need to do an anterior OCT. That's a very important issue. And when we discover that we have a Descemet's membrane detached, we need to refill the AC with the air. The filling is not from the paracentesis that we used. We need to go back and then fill the air, because that will do an internal massage to the Descemet's membrane, and it's reattach it in a beautiful way until the end. And that's very important.
Thank you, Dr. Safwan. Dr. Amal, if you have any comment, please, before we move, in within 30 seconds, please.
Thank you, Doctor, for a great presentation. And I think the most important message that was delivered, that big disasters always start with small mistakes. So whenever you have a descendant membrane detachment, you should stop immediately. And at the end, you should avoid hydrating the wound and address the issue, inject an air bubble in the anterior chamber, and don't wait and see, okay, the things will be okay. Because I have encountered patients who had DSEC done at the end after a descendant membrane detachment at the entry wound of a simple phacosurgery. So that's a very important issue to be addressed.
Thank you, Dr. Amal. Okay, now we will move to the second talks by dear friends, Dr. Yasin Dawood, and he is going to cover phacoemulsification iris-related complications. Dr. Yasin.
Good evening, Dr. Sharma. That was a tough act to follow. Thank you so much for all those wonderful videos, and always learn a lot from you. So thank you so much for being here. Dr. Amir, thank you so much for the invitation and for the esteemed panelists. So I'm going to start with just a few videos. Before I do, there are a lot of iris problems that we encounter actually at a routine cataract surgery. It could be just the fact that, for example, uveitic cataract, synechialisis, and synechii, anterior or posterior synechii. It could be actually something that is congenital, where the patient is born with iris coloboma. It could be actually something that the patient was not born with, but we gave them that during our cataract surgery. Such a patient like this that was referred to me. It could be that the patient did it because they were having a little bit of a fight with somebody else and really ended up having significant iris trauma, or it could be that the surgeon themselves gave them this significant iris trauma. So based on the time that is allotted to us, we'll go over all of these cases. And there are some cases where the iris could be your friend and could be your friend and your adversary at the same time. So we'll just, for the benefit of the time, we are just going to go through some of the surgical things that we're going to do. Some of the tools that we have, we do have multiple different kinds of rings where they have different properties, and we have iris hooks that has been there and in existence for a long time. So I'll start with this uveitic cataract in a young patient with a white cataract. And you can see that there are significant synechii. With the significant synechii, one of the things that you want to make sure is that as you are actually pulling a little bit, you definitely don't want to give the patient iridodialysis. And the best thing to do is mostly push rather than pull. And when you push, you are putting much less stress on the iris root. Then once you are done, this is a patient actually, I decided not to do trypan blue because there's a lot of pigment on the anterior capsule that I can actually follow to do my capsulotomy. I don't really recommend that in the vast majority of cases. I myself use trypan blue liberally, and I think it's reasonable to do that. And then you can proceed with your cataract surgery normal. As you can see, what I do for the iris hook, I insert one, and initially I put viscoat underneath the iris to elevate the iris up so that it's easy for me to implant my iris hook. And then I do it sequentially. I do my paracentesis all at once, and then my iris hooks all at once, and then clip them all at once. This patient has received an MA50BM. It's just a 3-piece IOL. It's my favorite one in patients who have uveitis or zonular problems in case I need to do something. This is a one-handed technique of removing your iris hook. And you can see just a tiny bit of a push. If you actually push it forward, let me just go back for 2 seconds. So if you actually push the iris hook forward a little bit, and then you have to tint up so that you can relieve it from the iris. And we just kind of got rid of the video. And then what happens is you can actually remove it in just one hand. In that process, you have to be very careful that you are actually not capturing the iris or the capsule as you're coming out, because you could cause iris tear or capsular tear. So this is just a quick use of iris hooks. One of the things is you can use any technique to dilate the pupil. However, if there are any zonular issues, it is actually better to use the hooks for multiple reasons. When you use the rings, they're going to actually stand in your way, give you anterior resistance, which means things are going to go back, and that's going to cause more stress on your zonules. You can actually, as you'll see in the later one, I will be using the iris hooks to stabilize the capsule when I see that the capsule is weak. And we talked about the one-handed technique. You feel free to do the two-handed techniques. Now, one of the things that have gained in popularity in the United States, I don't know how available it is overseas, is the Malyugan ring, and there's the eye ring, there's the Visitech ring, and now there's the Canabrava ring. So many different things. Basically, the basic technique is how can I increase the points of contacts of something against the iris. The Malyugan ring is a polypropylene. The nice thing about it is, as you remember, the hooks, you usually use 4, you may use 5, but with the ring, you're actually having 8 points of contact with the iris, which minimizes the stress on the 4 points of fixation, but also gives you a little bit of a rounder iris than a hook would. So I'm going to show you a few videos with what I do with these rings. The insertion is pretty simple. Sometimes you may be able to hook onto one of the eyelets into the iris. Sometimes, if you're lucky, you may be able to put 3. Sometimes it's 2, but it really does not matter. As long as you get the ring in with less trauma. Of course, these patients are under topical, so you have to tell them that you're going to feel a little bit of a pain or discomfort now and a push. The second thing is that you have to recenter. Once you actually have done that, you have to recenter the hooks. When you remove the ring, there are multiple ways. It's much easier to come from 180 degrees than sub-incisional. This technique is you just release one, you insert the Malyugan inserter again, and you hook one of the eyelets. You don't have to hook the eyelet, but it's much simpler, less traumatic. And the moment it is parallel to the wound, you actually bring it out. You don't have to wait until all of the ring is actually inside of the barrel. In this case, you can see this is actually a femto case that I was doing, and the patient basically had a constriction that I could not do with the viscoelastics or with the epinephrine. And now you can see that I'm really having a hard time actually positioning the ring into this iris. Now you can see the technique of me going 180 degrees away to just get access to that eyelid to bring it forward. And then finally, you can see that I'll position the last one. This one is rather stubborn for some reason, but eventually you can get it. Let me stop here for a second. If you have a hard time where the hook is just basically, sometimes you get the Malyugan manipulator and the iris tucked into the Malyugan manipulator, you can just go with your second hand with any second instrument, Sinskey or your iris sweep, and you can actually dislodge it that way, and that should work just fine. Now, how to remove this, we showed one technique. The second technique is the clockwise dial or counterclockwise dial, where you'll see that I will release one, but then the moment you start dialing it, it releases by itself. That way, the patient doesn't feel it. You are not traumatizing the eye very much. Again, once you have it parallel, you can remove it. This is actually a case that was not done by me. As of yet, I'm not the surgeon. It's one of our surgeons. I was in our center, and he's a fantastic surgeon, glaucoma, but somehow as he's putting this is pseudoexfoliation patient, and he's inserting the lens, and you'll see that as he's getting the lens in, sometimes these rings give you a hard time, and the ring goes behind the iris. The most important thing is you just have to breathe. You have to think what happened, and you have to reverse what you did. So now he basically called me up, and this is now me coming in, and you just have to dial things to see what is going on. Where are the eyelets? Where are the haptics? And you have to be careful with your, while you're coming out, not to capture any of your capsule. So here I'm like, okay, well, what's happened? It looks like the optic actually pushed the ring down, but sometimes you will actually find the haptic going through the eyelid. That's much more difficult to do, but it's still doable. And what I need to do is I need to dial this in a fairly atraumatic way. So I'll come across actually now with my Sinskey. I've already liberated these 2 eyelets, and I'll try to push it, but you'll see that one of the third is coming out, but not the fourth. The fourth is rather stubborn. So now I just have to go pretty close to where I am here. And I have instead of going blind, I want to get a push-pull Kuglen hook to see what am I dealing with. I'm like, okay, good. So this is free. I'm not catching anything of the capsule and whatnot. I can go if I can and get the eyelet, or lucky enough, it just came on its own. And now you can see handshake technique of me removing it. And that's basically what you do, and you just finish the case. So the Malyugin ring is a fantastic ring, but any of the rings really do well. I usually prefer the 7 millimeter. They come in 6.25 millimeters because I do a pop and chop technique. One of the pearls is if you really do have a significant floppy iris syndrome, you can actually use the ring and put what we have mypol or myostat, which is acetylcholine or carbachol, and that will constrict the iris around the ring, and that will stabilize it so it doesn't come out of your wound. So that's one pearl. The second thing is if you really consider using any of these rings, you have to watch out for retained lens fragments because they actually go underneath the iris. The iris is floppy, so their segments are going to come with your fluidics. But if there is a ring, they're going to get stuck until, and then you'll see them the next day, and then you have to take the patient back to the operating room. The insert or dislodge, it's easier to go from 180 degrees. You have your main incision, you have paracentesis. It's easier to go 180 degrees than to struggle with it in the subincisional. Now that we have moved from those things, let's talk about iridodialysis, iris defect repair, pupilloplasty, IOL fixation to the iris. So this case is actually, the iris is not a problem. The iris becomes your friend. And this is iris sutured IOL. You basically fold the lens. This lens is about 6 millimeters optic. It has 10 degrees posterior angulation. You fold it in a mustache technique or in a palm tree technique. You have to be very careful with this, that this trailing haptic has to go first because these are PMMA haptics, otherwise they'll break. Then you, as you are opening the lens, as you are unfolding it, you want to make sure that it does not snap back and go back. So you put any second instrument to hold the optic up while the haptics are getting underneath the iris. And then you have any of CIF4 or CTC needle. CTC is because it's curved, STC it's straight. And then you just have to go to the mid-peripheral iris and get very small nibble of the iris where you are passing through the iris underneath the haptic, through the iris, through the cornea. And then you'll see that I am doing the same exact thing on the other side. You can go through the cornea or you can go through your main corneal incision. The most important two things, you want to go to the mid-periphery so that you don't have a cat eye appearance. Then you have the paracentesis where the haptic and the suture are meeting right here. You take one end of the suture out, you hold the second end, and then you externalize both of them. And you can use a mechanical suture technique, or you can really use a Siepser knot. I don't recommend the fourth row pupilloplasty because I don't think it's tight enough to withhold the weight of the lens in these scenarios. But now you want to really go down and cinch it down on your 311 so that it doesn't dislodge. Then you can just cut it short or long. It doesn't matter as long as you don't cut your knot itself. And then you basically with the Sinski, you actually will push one way and then you'll push towards the haptic optic junction right here with the suture. And that could be that the iris is your friend in these surgeries. Here is actually a 32-year-old teacher, and she doesn't have much of a lens problem as far as cataract, but you can see that she has significant zonular problems. This iris is not pharmacologically dilated. She actually, this is her iris from the trauma. She came in with documented pressure of 50 because the lens was actually intermittently moving forward. So I removed the lens and I'm like, okay, this is before the Yamani technique and the glued IOL at that time was still new. And I was like, okay, well, what can I do to fix both the problems for this patient? She has weak zonular support. She's still rather young and the iris is pretty dilated. So you can see me tugging on it. You have to be very careful as you're coming in that you do not cause iris root dialysis. Sometimes you may see some heme, but you'll see that I put the lens in. Remember, I said take as little piece of the iris as possible with this technique. However, because we want to make this iris smaller, you can see me going and taking a nice chunk of the iris to actually bring it together because this iris is so dilated. And I use the same exact technique. In the interest of time, you will see that I am finishing and you will see the beautiful iris coming down. The lens is already replaced. The lens is supported and the pupil is fairly round, and she's doing very well with it. This incision, by the way, is a 4.5 millimeter. So this is a technique of iris suturing through a mechanical suture. And this is the patient, I think, 1 week actually after the surgery. This is iris coloboma, the same exact technique. This is a patient who came in for cataract surgery and they had coloboma. You have to be very careful because usually there's zonular coloboma, but in this patient, actually, you can see that the zonules are very reasonable. I'm not having any problem with the lens being decentered or with the lens being pushed one way or the other. So I feel very comfortable with the zonules that I'm like, okay, this is just going to be a routine cataract surgery. But I have had patients who come in with, you know, all the way coloboma from the iris to the zonules to the lens to all the way to the retina. And then you finish, you do the surgery. I usually like the pop and chop technique. You can easily do it within 5.5 millimeters, capsulotomy. And once I am done with the cataract, again, I'll pass it through. So this is, in a way, the iris is bystander, but the patient is photophobic, the patient's having problems. I hold the iris with a 23 gauge forceps, retina in the grasping forceps will work, or any of your micro forceps, and you will see that you pass it. You can go through the same exact technique. Then you just bring the sutures out, and you just have to go. And what I use for this is actually I use a Lester hook. It does much better than a Sinskey hook because it has a bulb on it on the end, so it actually holds the thread as it is coming out. And you should never go into your angle blindly. So you can actually get an iris sweep, go in, bring the thread out to your view so that you can bring it. And you can see that the iris actually approximates really nicely. You can do CEPSA, you can do pupilloplasty, but whatever technique you do, this is a very convenient and very quick and you know, things that are available in routine cataract surgery. This is the same thing, but in the interest of time, I'm going to pass on it because this is a patient referred to me and I do the same one. I'm going to show this surgery actually. So this is a patient that came with a trauma, with a little bit small iridodialysis, and with a little bit of zonulopathy in that area. And the patient was like, I don't want to wear glasses also. I'm like, I can't promise you anything. The most important thing with iridodialysis is you really want to isolate it first, because this, you know, this doesn't have any counter traction. It's going to be flabby the whole time during your cataract surgery. So I use 2 hooks in this area to really isolate it. And then I use 5 hooks. So it's like a house shape rather than a round shape. And I basically start doing my cataract. The cataract is uneventful, but I am worried about the lens itself, just because this area, you know, looking at it in the slit lamp, I was not very happy with it. So in this case, I'll just remove the cataract.
Dr. Yasin, can we fasten this one because we already over 2 minutes or 3 minutes above?
Oh, really? So, okay,
Yeah.
so I'll show the last technique then, which is a Hoffman pocket. And in the Hoffman pocket, what you will do is you can actually have a 350 microns, and you have to go through the same corneal incision. This is an STC6 needle. It's a straight, you can curve it if you want. And for this part, you're gonna have just the smallest part of the iris, and you're gonna come through the Hoffman pocket. You can use a 27 gauge needle from the outside to bring it in. And that has become my favorite technique rather than just going blindly through this. So you take it out and just 30 more seconds. So this basically, you have to make sure you go through the same exact paracentesis port. You could get a cannula to actually externalize and get the needle through it to make sure you are going through this. Because if you have any corneal tissue, your thread is going to be actually stuck here, and then you have to redo the whole thing again or try to rescue it. So you can actually get it. And again, you want to get the smallest part of the iris so that this does not peak. And when you get it, you have both sides now. You'll see that I'm pulling. Then you can get Sinskey hook, externalize these. You know, you'll see one, then you'll externalize the second, 350 depth, back about 3 millimeters, because you want to give yourself a good room. You have these 2, you do them 3-1-1, and basically the iris looks fantastic. And I will stop with that. You can use this the same exact technique with this part, and eventually you do the patient basically does even well with with iris problems. So the same exact technique, just use it 4 times around. Thank you so much for your attention. I'm happy to take your questions at the end.
Thank you very much, Dr. Yasin. Very nice and excellent presentation, excellent video showing the techniques that you are using to repair the iris. So we don't have a time, so maybe we'll keep the discussion about this presentation maybe to the end of the our sessions.
Sure.
So without any delay, we will go now directly to the third presentation. It will be by Dr. Zena Al-Muhtasib, phacoemulsification, anterior capsule related complications. Dr. Zena?
Sounds great. Thank you again so much for having me on. Can you see my PowerPoint?
Yes.
Excellent. Thank you, Dr. Amri, and to the committee for having me speak. So I'll get right into it. And I actually have an alarm for 12 minutes.
Highly appreciate it. Thanks a lot.
Okay, great. So I'm going to talk about capsule-related complications during phacoemulsification. So I'll talk about how to perform a good capsulorhexis, when to use trypan blue, discuss the little maneuver, and some difficulties with anterior capsular fibrosis, white cataracts, and then talking about some complicated cases in terms of trauma. So really the best way to deal with complications is to prevent them. So you want to do a very good preoperative history. You want to make sure to understand, are there previous trauma? Is there a poor red reflex? Are these patients have previous surgery, ocular surgery, which changes things? And then, of course, be aware if patients have risk of radialization, if this is a patient with a shallow anterior chamber, mature white cataracts, pediatric cataracts, and then, of course, zonular laxity. So to perform a good anterior capsulotomy, you want to make sure to deepen the anterior chamber with OVD. I like puncturing the capsule with a cystotome and then creating a flap and then using Utrata forceps. It's important to hold the capsule in the correct location and do shearing. So you're about 2 to 3 clock hours away. Residents, when they start, you want to keep grabbing and grabbing. The least amount of times you grab, the better it is. And then you want to make a size between 4 to 6, ideally around 5 millimeters to avoid PCO formation and then capsular phimosis. As you know, the zonules are actually wanting in the periphery to create radialization of your capsule. And that can be magnified if you underfill with OVD, or if there's shallow chamber, or if the lens is anteriorly located. So you got to understand there's forces that want you to radialize, such as vitreous pressure, and then decreasing anterior chamber. So when to use trypan blue? Anytime there's a patient with a trauma, poor red reflex, it's a dense cataract, and then of course loose zonules. I staff a lot at the county hospital, and the little maneuver was one of the best techniques that saved us from JCRS in 2006. And I'll show it in video form, but basically if you start feeling that your capsulorhexis is wanting to go out, you want to put back your flap, and then pull towards the center, but don't pull too much, and then reorient the flap. Some people go to the center and then it cuts off completely. So let's watch a video. This is one of my residents operating. As you can see, the actual capsule starts wanting to radialize. So you can see here, I tell them to flap it back. So that's really important in terms of that. And then you want to pull to the center, but not too much, because you only want to change the trajectory of the capsule. You don't want to, bring it all the way to the center. So again, this is slowed. As you can see, I'm using the BSS bottle to tell them where to go, but basically you're reorienting. And sometimes it's a lot harder to do. This is one of our other residents. Again, what's nice is that they did not underfill the anterior chamber. But what you can see here is, again, when you do too much with the cystotome, you're doing too much maneuvering, you can start losing where your capsule is. And this is a case, you can see that this is a dense lens that he probably should have put trypan, especially when you're starting out. It's so much easier. And so again, he's struggling, he's grabbing, and it's hard to tell here, but what's happening is it's going out completely here, almost to the periphery, to the equator. So I take over, and spend some time with the OVD cannula to see what I'm doing. And I blindly do the technique of the little maneuver where I'm going to the center. And you can see you want to grab as close as you can to the edge of the capsule, go to the center, and then reorient your utratas and just continue your capsulorhexis normally after that. So it's really important to know, just trust it, just pull it straight and you'll be able to save it. So let's talk a little bit about doing a rhexis in anterior capsular fibrosis patients. So I like using trypan blue, putting in OVD, lifting up the iris off of the capsule and being very careful when you do that, not to tear the capsule. So I go with my cannula underneath. One key pearl is use the cystotome around the area of fibrosis. Don't try to make the opening in the actual capsular fibrosis. So you want to incorporate it into your anterior capsulotomy. So again, you're going around and then just removing it, and you do it all around that area of capsular fibrosis, and then you're able to kind of proceed with the surgery. Another pearl that I like is sometimes I like restaining with trypan even after I do the anterior capsulotomy. And the reason for that is you want to see that capsulotomy during the whole time, because sometimes it's just not, you don't get as much of a good stain. And what if you're not sure, has it been, again, circular? Has it been around? So in terms of the interest of time, we'll go kind of to the next case. This patient also had zonular loss. So in these cases, again, I go in with my cannula. Sometimes I have to use a needle. You want to, as I'm injecting OVD, I'm lifting. And then Dr. Yassine Daoud did a great job about discussing kind of these tough cases. And I agree with him. Sometimes it's very hard where you have this remnant pigment on the anterior capsule, and you can easily cause a tear in the anterior capsule. So again, I remove the OVD, I go in, I restain with trypan, and then I want to puncture the capsule in the location that there's no pigment. And I want to make sure to remove the pigment as I'm doing my capsulorhexis technique here. And then again, I make sure to go in the orientation in the circular way and make sure to remove this, this fibrotic membrane, and that's remnant pigment. And again, I restain because it's very hard to tell if there's areas where there's a tear in the capsule in these cases. And then even if you're doing a triple procedure, as I do here, you can still use the Mayugan ring in terms of opening up the iris. And again, when you have this surprising, very significant capsular fibrosis, it's a little bit harder because you don't have the OVD pushing down, right? And you have the lens anterior. So that capsule wants to radialize regardless. You want to make that capsule as small as possible. And if you look, I'm orienting my capsulorhexis technique to the center of the eye. Basically, I'm doing a little maneuver for the whole process. So I'm not going circular. I'm basically just aiming towards the center of the eye here. As you can see, just basically little maneuver going forward, little maneuver going forward. And that's really the technique to be able to perform this capsulorhexis here. A lot harder, obviously, open sky, but again, it's all the same principles that you've utilized. And then in this case, got lucky enough to be able to have a round capsulorhexis. So just remember and try to incorporate that fibrosis into the rhexis, and it's okay to restain. Trypan blue is your best friend. And then use OVD and lift up the cannula. So let's talk a little bit about these white cataracts where you're worried about Argentinian flag sign. I like utilizing a 27 or 25 gauge half-inch needle and making sure to decompress. I only make 2 paracenteses, fill with trypan, fill with OVD, and then I use the needle for a different entry. I don't make my wound. And the reason for that, I'll show you why. But in this case, you really need to, I shouldn't have aspirated as much because you can easily puncture the posterior capsule. But again, in this case, when you do remove some of that, just remember that in the periphery, you can have some remnant white cataract that's liquefied and it can still want to radialize. And also when you pull out too much, sometimes you can fill the bag so that you can still be able to do the rhexis. And the reason, again, I stopped doing my wound is, look at this case. So paracenteses, wound done, going in to decompress. As soon as I touch the anterior capsule, you get that Argentinian flag sign. And I think part of it is you don't want any openings, and sometimes that can happen. There's just so much tenseness from it. You can still put a one-piece lens. You can still remove this capsule. There's a little bit of I don't like that there's you don't have the visual axis open, so I open up that rhexis a little bit more, but the patient can do very well. So what about patients with trauma with anterior capsular violation that's already there? Again, use trypan blue, use OVD to kind of see what's going on here. This is a 7-year-old Cetaspos open globe repair. I love using iris hooks when I'm not sure what's going on. And then I want to open, there's a lot of opening in the anterior capsule, so I just aspirate. So again, I can see where is the anterior capsule, where is the posterior capsule. And you can make paracenteses in any location that makes it easier for you. Don't have to be kind of your typical orientation. So in this case, I use a paracentesis in a different orientation to help me, and bimanual irrigation aspiration is phenomenal in these cases. You can see there's a big, large U-shaped anterior capsular fibrosis. So I make a cut there because that's going to be in the visual axis. This is a young patient. I also want to do a primary posterior capsulotomy because I don't like putting 3-piece lenses in these kids primarily. I like to do optic capture. And then also they're going to need a YAG. A lot of research from India shows a patient with traumatic cataract that's a child will get PCO very quickly. So again, the forces are very different when you're trying to do a posterior capsulotomy. It's almost like doing open sky pediatrics in general. Again, you're aiming much more towards the center than circumferentially. And then in this case, we were able to do a primary posterior capsulotomy. I put in the 3-piece lens and then basically just optic captured it. I put in triamcinolone just to make sure that there wasn't any vitreous around the zonules. I'll skip this case, similar because of time. I won't really go into much about posterior capsulotomies, posterior PC tears, because our next speaker will do it. I just wanted to show one case, kind of how to approach it from an anterior segment surgeon. This is one of our residents. Sometimes these soft lenses are much more difficult to remove than our a little bit denser lenses. They're not able to really grab that. And as you can see, the phaco is, they're phacoing without really seeing what's behind the posterior capsule. And in this case, at this point is where I noticed that they actually have a large posterior capsular tear. The anterior capsule is intact and an elongated, but then there's remnant capsule. So just a couple of points on doing anterior vitrectomy. You never want to remove your instruments until you put OVD, as you can see here. It's nice with the newer vitrectors, they go through the paracenteses. You can turn off and on the cutter. So initially you do the anterior vitrectomy, use triamcinolone, and then once you've removed the vitreous from the anterior chamber, you can keep the cutter off, but still use the vitrectomy to do irrigation aspiration of this cortical material. And again, never remove the instruments without putting OVD in the eye. You never want the chamber to shallow because more vitreous can actually enter. And again, I restain with triamcinolone. It's also anti-inflammatory. It's really great. Here I put in OVD. Sometimes I use an iris hook, make sure that there's no vitreous strands. And then what do you do in terms of the lens? I like doing the 3-piece lens, which we showed in that previous case. And then optic capture is always better. So these are some of the pointers that I talked about. I like using MyStat at the end. And then I just want to spend about a minute to talk about what types of lenses to actually put into different patients. So if you have an anterior capsular tear, but the posterior capsular is intact, you can put a single piece acrylic and then rotate the haptics and make sure that it's perpendicular to the tear, similar to the case I showed prior. But make sure never to let the chamber shallow, constrict the pupil, and suture the temporal incision. What if you have a posterior capsular tear, but an intact capsular rhexis? The ideal situation would be a 3-piece IOL with optic capture. It's much better to utilize optic capture. can place single piece in the bag with small tears, but I try to avoid that. And then you don't have to adjust the power, which is more important in larger power lenses. And why is it important to do optic capture? One is the 3-piece lenses that we utilize in the US have relatively short haptic lengths. So especially in long eye patients or large diameter anterior chamber, it's going to keep bumping. And especially in younger patients, it can cause UGG. And then also it's nice to do optic capture because of the no change in IOL power. A great study showing that it's important to avoid decentration with optic capture. Most importantly, never put a 1-piece in the sulcus, as we know can have all of these complications, secondary glaucoma, hyphema. What about if you have an AC and a PC tear? If there's not enough support, sulcus is an option. I don't like doing that unless I need to. And so this is from a chapter I wrote about what to do in these cases. So as you can see, my preference is going now the Yamane intrascleral haptic fixation for those cases, but there are multiple different options. And so in general, get comfortable with different techniques, discuss with the patient, talk about these potential outcomes, and just be prepared it will happen to you if you operate. Thanks again for having me speak.
Thank you very much, Dr. Zena, for an excellent presentation. You cover most of the points. I think there is many questions maybe, but we will keep it also because we already over the time. So we will move to the fourth presentation by my dear friend, Dr. Ahmed Al-Barqi. He's a veterinary surgeon, and he is going to give his opinion from point of veterinary surgeon about, and his title of the topic, does and doesn't in anterior vitrectomy. Dr. Ahmed. Ahmed, you are with me?
Hello, can you hear me now?
Yes.
Okay, thank you, Dr. Muhammad, for the kind invitation. It's a pleasure for me to be here today with these distinguished speaker and the panelist. So my talk today is about the what should we do and shouldn't do in anterior vitrectomy, what happens if the vitreous loss and you manage it properly. So actually the story starts before we should know our target while dealing with vitreous loss during cataract surgery. Also, another important point is to expect complication before happening preoperatively. Intraoperatively, another important point is to recognize early some warning sign. I'm going to discuss that. It gives you an idea that something wrong is going on and you have to stop at certain point. For sure, the technique and the setting should be known, and finally, the post-operative care. So if you start with the target, what's our target in doing anterior vitrectomy in complicated cataract surgery? The most important point or aim is to prevent intraoperative vitreous traction or traction of the vitreous during surgery. And definitely the post-operative vitreous traction or adhesion to the wound of the side port, this should be avoided, and maintain a normal tensive globe at the end, and definitely to protect cornea, endothelium, or iris or capsule from any other damage, and definitely remove any remaining lens fragments or cortex. So expect complications. So I think it's very important while examining the patient or evaluating the patient preoperatively, we have a list of some problematic eye that it could have problem during surgery, like this list. So one of the signs, also early signs, that it gives you an idea that this news could be weak during doing the initial capsulorhexis, the tear in the capsulorhexis system. You find these wrinkles here, so it gives you an idea that this news could be weak. So you should take care during the surgery. So what I prefer actually in those kind of patients to expect complication, better to give a block rather than topical anesthesia. I know most of the anterior segment surgeons, they are doing it topically, but if you have some case like that, it could have a complication, better to give a block to avoid adding anesthesia during the vitrectomy because the patient at that time maybe have some pain or positive pressure or something like that. So I prefer to do an initially periorbital anesthesia. For sure, you have to keep the vitrectomy instrument standby and book additional time for and have a buck implant, which sometimes also very important. What are the early sign and warning signs? This is a very important point I want to highlight here. If during phaco, you can see some suddenly pupillary bounce or change the pupil size. Another point is the sudden deepening of the anterior chamber without any reason. So it could be the sign that the posterior capsule is open and you didn't notice that. Another important also point is the flow is lost with the lens material is not coming to you. So could be something blocking there. Another important point on the phaco efficiency. You are doing phaco and it's not efficient. So maybe the phaco blocked by prolapsed vitreous and you notice that, and this is very dangerous if you continue with phaco and there is a vitreous inside the probe. So if you find unexplained loss of phaco efficiency during surgery, you should think about it. Also, spidering the posterior capsule, and this is very obvious for all of us, tilted of the nucleus equator, and finally the hole bunch sign. I just want to show, for those sooner is the better, as we all agree about that. This is just a video to show you the, I don't know, oh, sorry. There is some delay in the, hello?
Yes, Doc.
Yes, Doctor.
The video, oh, okay, let me try now. Yes, okay. The video, I'm not sure. Do you see the video working or no?
Now it's
Yes,
working.
it's working now.
Yeah, now it's working now. Okay, so during phaco or during chopping, it is not my surgery. There's just a video to show that. So sometimes you find this sign, the lens, the nucleus equator tilted up. So I think you should stop at that time because this is a sign. It could be a sign of posterior capsular, and that's why I've seen here in the surgery the lens dropped. Another sign I told you about is the hole bunch sign. Yes, as you can see here, usually this happened during cracking or during the initial guttering using a high vacuum. This is not, this is, again, this is the, I don't know, there is some delay, I'm sorry for that, I don't know why. Anyway, there is another sign that's called hole bunch sign. Usually it happens, as I mentioned, during the cracking and using high vacuum in a relatively soft nucleus. You can see this hole while doing initial stage of the phaco. So if this happens, it usually prefer not to continue the phaco this time, preferably to remove the other fragment, the other half, and keep this quadrant to the end with this hole inside. And also you can add some viscoelastic behind to avoid any extension of the posterior capsular hole there. As you can see, this is gone initially. So technique is very important because it's very important to give another anesthesia if there's something happening. Sedation also is important. The most important point, as Dr. Zainab also illustrated in his talk, do not let the anterior chamber collapse. It's very important because once happen and you find there is a drop in the nucleus or vitreous loss, do not pull the phaco probe out of the eye suddenly, and go to just position 1, which is only irrigation, and then inject a lot of amount of viscoelastic, dispersive viscoelastic to re-visualize the AC, and then you can get out of the phaco probe, and better to close tight water suture. I will dictate you. This is how it happens. If you have low pressure in the anterior chamber, the vitreous will go, but if you re-pressurize the anterior chamber, you prevent more vitreous prolapse. This is just to show you the video how this could be done. This in the upper video, I'm sorry, there is some delay and playing the video. You can see the surgeon here, once he dropped the nucleus, he get out with both instruments suddenly, as you can see here, and there is a sudden collapse of the AC. If you look this proper management for this case, okay, this is the surgeon in this case, he did it properly. As you see here, he was doing phaco, and when the lens dropped, let's go faster a bit. As you see here, he trying to catch a lot of pitch, but it's dropped, so he get out with the chopper. Don't get out with the fake irrigation is still there. But with the other hand, put a huge amount of, be generous in doing a lot of dispersive viscoelastic to normalize and prevent more vitreous relapse. And then you can easily go out and you can see there's no collapse of the AC. So this is a proper way how to avoid more vitreous prolapse in the anterior chamber after vitreous loss. So the technique and during doing the vitrectomy, we need to reduce the vitreoretinal traction. So we should use the highest cut rate available in your machine with low flow irrigation and low vacuum to remove the vitreous. Again, we need to know that we are doing just anterior vitrectomy. Was not when we are not planning to remove the whole vitreous. We're just removing the vitreous from anterior chamber. So use the high cut rate with the low flow and low vacuum. For protective mode, if you are going to, for the vitreous, you should IA cut, which is cutting first and then aspiration. For lens fragment, you use aspiration first and then cutting. And this is how to show the fit bezel position. Also, triamcinolone is a very important trick or tip, as Dr. Zainab also, I think it's strategic, that to show you using triamcinolone. I think it's a very privilege, you know, because sometimes you have a small vitreous strand you can left behind while doing a vitrectomy, especially if you have some corneal edema, so you can miss some small vitreous strands. So I believe better to visualize, to stain it with triamcinolone to make sure that you really remove all the vitreous strands in the anterior chamber. What is the approach? The approach, we have two main approaches to do anterior vitrectomy: the paracentesis anterior vitrectomy, which is commonly being done using most of the surgeon, and the partial plana anterior vitrectomy. Personally, I prefer the partial plana, not being a VR surgeon, but I think there is some rationale for doing that. I think it's make more sense anatomically, and also it minimizes the traction on the vitreous base, and it's more efficient as you are calling a vitreous back home rather than doing from the anterior chamber. And also you can move all the attachment without too much sweeping and minimize vitreoretinal traction forces. The other approach is the, I don't know, there's some delay. This is how to do that. Sorry, this is for the partial plana, and this is for the paracentesis approach. And a new trick here is to use a separate incision for the vitrectomy. Do not use the vitrectomy for the main incision. Just to show you this video for the partial plana approach, I just show you. It's an easy done. I think it's not. Do not be a VR surgeon to do that. I think anyone can do that, because most of the vitrectomy machine, the phaco machine now, the anterior vitrectomy back have a trocar, so you can do it. And partial plana is not exclusive for VR surgeons. So I think this will make more sure that you remove most of it. And also you have easy access to the lens material or cortex. You can remove it easily rather than the anterior, the paracentesis approach. The paracentesis approach we already discussed it during the this is what I mentioned about the separate. Use separate incision for the vitrectomy rather than doing the treatment to avoid leak. If you look at this in the left hand side video, if you use a separate incision or use the vitrectomy or use the paracentesis, you have minimal leak here, rather than if you use a vitrectomy probe through the main incision. Yes, you can see here a lot of leak, and the EC is unstable, and more vitreous will come. So I prefer to use the side port for the phaco rather than an incision. Setting, I think another important point: what happens if you have some fragment fall in the vitreous? Do not chase it. It's very important. Do not trying to grasp it with the phaco probe. It's very dangerous, because you might induce retinal tear by pulling in the retina, and you have leave it behind. Don't do a lot of maneuver using a phaco probe. Just if it's fall down, don't chase it or try to do that. It's very, as you see here in this cartoon, it's very dangerous, because using a phaco probe in a vitreous, it's very dangerous because of the ultrasound, and you can easily induce a peripheral tears and even big tears. Sponge vitrectomy, definitely, I think we should all agree there is no rule now, because it's really induced very excessive traction on the vitreous space. For the final step, for sure, you have to remove the residual cortex using the setting, as we mentioned before. IOL implantation, we have a list of options, as Dr. Zainab also illustrated, so you choose whatever you want. Finally, constrictive removal is important, because you want to make sure that the lens an IOL in place, and also there is no pupil peak, no vitreous strand there. And finally, you have to make a watertight closure of the human incision. So post-operative care is very important. You can consider intraoperatic. NSAID is important, because we have a high incidence of macular edema. Better to refer the patient for retinal specialist for retinal examination. Also, a very important point is to educate your patient or disclosure, so that something happened and we manage it. and you should, if you have any symptoms of floaters or flashes of light, you can come easily. So it's very important to disclose to your patient what's happened. So to conclude, there is a list of something we should do, like the knowing, especially know the correlate or early recognition of the warning signs, predict complication, the technique, post-operative care, and educate your patient. On the other hand, we shouldn't panic. Just do not pull out the phaco probe suddenly, reform or keep the pressure inside the EC very informed to avoid more vitreous flap. Do not chase fragments or trying to do phaco while I'm not sure there is some vitreous there. Do not do sponge vitrectomy. I think the take-home message with this comprehensive strategy to deal with the vitreous loss and to get ready in advance for loss of vitreous, this treating the patient with logic and care, I think this will lead to achieving optimal outcome, even if you have complicated case. Thank you so much. I hope that I stick to my time. Thank you.
Thank you very much, Ahmed. Excellent presentation. And yes, you have your time, 15 minutes. So we will have also the last talk, I think, because it will be better now to discuss all the things at the end. So we'll have now Dr. Saad. He will give us a talk about endophthalmitis, and he give a title about to say that post-operative endophthalmitis, the untold story. Dr. Saad.
Great, thank you, Muhammad. Can you hear me and can you see the slides?
Yes.
Great. Okay. Thank you. Well, thank you for the invitation. It's always great to be back with you. Always, distinguished speakers, wonderful panel. Since I'm a vitreoretinal surgeon, I feel like I'm a minority among all the anterior segment surgeons around today. So I'm going to do my best to be careful on what I say. But I choose to speak about this. It's a topic that we don't usually like to speak about. People do not believe it will happen to them. But trust me, if you are doing phaco, and even if you're the best phaco surgeon, one day you will notice and see these cases. So without further ado, I'll just... Okay, so let's agree on a few things at the beginning. This is a bad disease. Endophthalmitis is rare, but it's a sight-threatening complication. These patients can sometimes end up losing their eye. The chances are very low. We're talking 1 in 1,000, and it involves inflammation of both the anterior and posterior segment. I think the most important step is the early recognition, the rapid treatment and initiation of therapy. If you do that, you have a good chance of saving patient vision. I'll try to see if I can convince you of earlier surgery for these patients. Different ways of classifying endophthalmitis. Our interest today is to talk about the post-cataract endophthalmitis, but you can get endophthalmitis after any intraocular surgery. The incidence is a bit higher after secondary IOLs. Now, when you're doing cataract, the chances are higher with clear cornea. And obviously, if you develop any of the complication that has been mentioned, specifically the posterior capsular rents or tears. If you look at the incidence of endophthalmitis over years, you will notice that, back in the early 90s, it was like 2%. And now in 2009, it's almost 0.03%. And in a very recent article that I unfortunately don't have citation for, I think it was from China, it showed that the incidence is even less. Now, the most common organisms are the gram-positive cocci, mainly the staph and strep, and if you're unlucky, you might get a gram-negative organism. Now, it's very important to realize or identify the risk factors, specifically preoperatively. And of notice is infection of the lacrimal drainage. And I still remember this patient was referred to me for cataract surgery, and he had a nasolacrimal duct filled with pus. I did advise him to fix it first, but unfortunately he went somewhere else. He did his phaco and he comes back after a week with endophthalmitis. So definitely you want to make sure you treat chronic blepharitis, you examine your patients preoperatively. Intraoperatively, if you get prolonged surgery, if you develop any of the complications mentioned by wonderfully by the previous speakers, definitely you want to be careful. One of the things I noticed from our anterior segment colleagues is that I don't know what is the problem with the corneal sutures. They don't like to put corneal sutures. You know, if you develop a posterior capsular rent, I strongly advise, or if you get a vitreous into the AC, definitely put a suture. But I think it has to do with the ego, I think, of the anterior segment surgeon. And post-operatively, definitely if you get a wound leak or vitreous incarceration, you would like to be careful. Now, endophthalmitis is a clinical diagnosis. These patients come with symptoms, usually within 1 week of the surgery, and you have to have high index of suspicion, specifically for your training residents and fellows, you know, younger ophthalmologists. Pain is very important, but I would show you a case where the patient had practically no pain. Loss of vision is very important, redness, discharge, and the hallmark of their examination is the extensive anterior chamber reaction, the hypobion and the fibrin formation. And then you do the B-scan and you see the classic picture of the vitreous opacity. Now, once you've diagnosed the case, you would like to consider a vitreous tap, plus or minus an AC tap, and that is extremely important to be done as soon as you can. And you know, when I do that, I usually call my microbiology and I make sure they expect the sample and they give me an immediate gram stain, and then we follow the culture and sensitivity. In the same setting, you want to prepare the patients for intravitreal injections. I routinely use steroids with antibiotics, but some people may not use it. I think steroids have a major role to control the intraocular inflammation that is very significant in these cases. And you know, there are different antibiotics that have been used. We use vancomycin and ceftazidime or amikacin, followed by topical steroids, usually fortified, very frequent drops. Now, as far as the use of systemic antibiotics and systemic steroid, this is controversial. Now, what has changed from the time of the endophthalmitis vitrectomy study? I would say everything has changed. EVS has been done 30 years ago, and it's very hard for me to convince me that we should still follow the study. I just don't think it's applicable. EVS was done at the time where vitrectomy techniques were different. We did not have the sutureless, the smaller gauge vitrectomy, the better cutters, the better visualization. So I think in my practice, I think it is different. Now, I'm not going to go over the study because you're all aware of the study and how did it classify patients according to vision. But I think there is major benefit of doing earlier and aggressive vitrectomy, including debulking the vitreous, removing the bacteria and the toxin, improving the visualization, delivering the antibiotics. Yes, it is a procedure that has complication, but I think in the era of micro instruments, we're talking now 27 gauge technique. I think the complications are minimum. Now, I think in 2021, I think the picture is different. Studies have shown, and there is a growing body of evidence from the recent literature that earlier surgery might have better techniques. And I'll see if I can convince you by showing you a couple of cases, but I think for the interest of time, I'll just show one case. So this is an elderly gentleman who come to us, 70-year-old heavy smoker with chest issues, and he's known hypertensive and diabetic with loss of vision in both eyes, very dense cataract in his right eye with light perception vision, and an equally dense cataract in the other eye with 2200 vision, seen by the anterior segment people, underwent an uneventful phacoemulsification. You can see the pre and post up pictures. His cornea was pristine, very mild cellular reaction, improving visual acuity to up to 20/60, giving the usual post-operative drops, and sent home to come for his 1 week visit. He comes to the clinic after 1 week with loss of vision. His vision came back to light perception. Now, interestingly, this guy had no pain. He said a little bit of discomfort. I don't think he was bothered because maybe his vision was so bad for so long, so he didn't think that was an issue. Now, when we examined him, he had the classic hypobion, shallow AC, fibrin, constricting the pupil with posterior synechii. So at that stage, this happened during the COVID era, and in our hospital, I'm sure like everybody else, they will not admit the patient without doing a COVID test. We have to do the test for him, which will take at least 3 to 4 hours. We have the rapid test. So at that stage, I was called to see the patient. It was like 3 p.m. in the afternoon. So instead of waiting for the COVID and admission and doing a vitrectomy, I elected to inject him, tap and inject the patient. And then by the time we did that, we did his COVID test. And we sent for the results, the sample, the vitreous tap, to cultures which initially showed no organism with a few polymorphs, and we injected him, of course, with intravitreal antibiotics and steroids. And within 24 hours, he looked a little bit better. His AC was still shallow. There was no hypobion. The fibrin was still there, and his vision was still the same. He was growing coagulase negative gram-positive cocci, and at that stage, we elected to take him for surgery, and I'll show you his surgery. So this is a 23 gauge vitrectomy. You can see the corneal edema. It's important to take care of the anterior chamber first. So you want to clear the anterior chamber of the hypobion. You want to remove the fibrin, sometimes by one of the forceps. I try to break the synechia. I see the cortex. There's still some cortex remaining. In this case, you try to, as much as you can, expand the pupil to improve your view, clean the anterior chamber. Now, it's advisable when you're doing this to keep the infusion to the posterior chamber shut off. Otherwise, you will have trouble. Once you do that, you turn your interest to the posterior chamber. I like to do a posterior capsulectomy where I remove the posterior capsule. In this case specifically, I'm trying also to remove the cortex. I do not routinely remove the lens in these patients. This is the vitreous, and after doing a core vitrectomy, you can see the opacified vitreous, the amount of vitreous inflammation. You will soon notice the extended retinal hemorrhages, and I'm trying also to remove the cortex, the remaining cortex. I think we're advised now to do more than a core vitrectomy. If I used this case 10 years ago, I would just have done a core vitrectomy and injected antibiotics. But now I'm doing more than that. Studies have shown that you want to do more than core vitrectomy. You would like to try your best to induce a posterior vitreous detachment. It's very risky, but you want to do your best to do that. As you can see in a few seconds, I'm trying to hold the posterior vitreous, and you do a combination of tangential and anteroposterior traction to try to remove it as much as you can. But of course, you want to use your personal judgment. Otherwise, you will run into problems because the retina is very thin. But you will notice that the picture will be much different after you've done that. You can see now the disc. So I'm trying to hold here the posterior hyaloid. As you can see, I'm trying to lift it up to try to induce the PVD very gently. And the idea is to decrease the amount of toxins and vitreous on the surface of the fovea and the optic disc. And once you do that, the outcomes and the prognosis is much different. And you can see the different picture now where you can see the actual disc and the fovea. There's still hemorrhages all over the place. The retina is very thin, but definitely the picture is different. Once you do that, you can inject your antibiotics at the end of this procedure, either through the ports or through the sclera. That, I think, concludes the case. Within a week post-operatively, you can see the difference in the top picture between intraoperative and at the end of the surgery. You can see the details where preoperatively nothing can be seen. His vision improved to 20/50, his IOP is normal, and within a month, this patient is gone into 20/40. Now, with still some hemorrhages, remember, he's also a diabetic. I followed this patient up for 6 months, and his vision is much, much better. He's 20/30, his AC is quiet, his IOP is normal, his retina is flat, and I don't feel we could have attained the same results if we have just injected him without going for surgery. Now, for the sake of time, I'm going to bypass the next cases. I think I have two of them, and then I'll talk to the conclusion. There are a few practical points, and I think this is for everybody. There's a lot of personal experience with these cases because they're not common. You want to err towards a bigger gauge when you're doing these cases, although 25 gauge works also perfectly. It's very important that the anterior chamber is cleared first, and when you do that, make sure the posterior infusion is off. you want to do more than a core vitrectomy. And if you don't have a good sample, a good piece of advice is to start a vitrectomy under air, because then you get a better sample. I do not remove the IOL. I leave antibiotics in the bag, and I do my best to induce a PVD. And if I cannot induce a PVD, I'll do fenestration of the posterior hyaloid to allow the antibiotics to touch the fovea. Now, the take-home message in these cases is high index of suspicion is extremely important. You want to train your residents and fellows to expect these cases. You have to accept it. I have seen some anterior segment surgeon sit on these patients for a couple of hours or even a day, thinking that this is just regular post-operative inflammation. I do sit with the patient and I talk to them about their prognosis, despite the fact that we do have a better prognosis with vitrectomy, but this is a bad disease, and most of these patients, unfortunately, do not regain good vision. Generally speaking, we've grown less aggressive. 10 years ago, I would be more aggressive with a diabetic vitrectomy, but with endophthalmitis, I think I've become more aggressive. I used to be less, but I've become more aggressive because I see better outcomes. Steroids are very important to me, and early surgery also, if the condition allows. And I think the best treatment for these cases is prevention. Thank you very much, and I hope I am still on time. Thank you for the
Thank you very much, Dr. Saad. Thanks for an excellent presentation. So we can have now the discussions, panel discussions, and also with the speakers. I think this is the most important to highlight some points. And we will start maybe about the first presentation that done by Dr. Namrata about the wound-related complication in phacoemulsifications. If there is any comments from any of the speaker, or we'll start with the panelists. Dr. Safwan, if you have anything, within just
Dr. Mohammed, just to allow me. It was in my mind to share with the speakers this 4 slides. As we said, that the first day is very important to say whether we have any corneal edema, and anterior OCT for the corneal edema is very important, and it's a must, in my opinion. So that case presents after an eventful surgery. Second day, they said there is central corneal edema. So I send him to the OCT, and that was the surprise. You can see the Descemet membrane detachment, and started from the wound, main incisions. So that's what's immediately, I took him to the theater, and as I said, I inject from the back, posteriorly, near to the 6 o'clock, the injection, the air, and you can see that the air flattening most of the Descemet membrane, and that was immediately half an hour after the air injection, and this is 1 week after the air injection, and that's the still, because I inject gas SF6, and that's the picture of the cornea. It starts to be clear, and that's my message to the speakers. Great, thanks for you.
Thank you, Dr. Safwan, to highlight this one. Okay, Dr. Yahya, there is, Dr. Namrata, she passed on many of the complications related to the wound, and
yes,
I think she highlighted so many things. If you can just give us, like, a points about this one, so to be kept in our mind related to that.
I want to ask Dr. Sharma and if to share her experience. In my experience, and this is an important point, with Descemet membrane detachment, if it passes undiagnosed, you can still attach it with very good results even after a month. There are some papers that says even 6 months. So I want to know Dr. Sharma's opinion, because some people will just be afraid to interfere. But in my experience, even if you interfere later, the results still are very good.
I agree with you, Dr. Eldon, completely. And very nice, nicely shown by Dr. Bayati about the anterior segment OCT. So we did a study where we took 100 consecutive cases of corneal edema which were referred to us. And in all those cases, we did anterior segment OCT. And we found that in most of the cases, the Descemet membrane detachment was there, and they were within 8 weeks. So I can surely tell you that within 8 weeks, if they present to you, And if you address them, then the Descemet's membrane will get attached.
Yes.
And we had a success rate of almost 80% in those cases where the Descemet's membrane did become attached. ASOCT is also very useful because sometimes the post-operative course is so stormy that you can't make out on a slit lamp where your detachment is. It's absolutely, the cornea is edematous, it is completely white, and you can't make out the area of detachment. So the first thing, if the corneal edema is persisting after phacoemulsification, is that you do anterior segment OCT and just rule out or rule in the Descemet's membrane detachment. So I completely agree with you that even after I think that one thing should always be done before you tell patients to undergo for endothelial keratoplasty, because there are times, in my experience, up to about 3 months or even 4 months, we've got the Descemet's membrane to attach if it was detached. It also would depend on the extent of the detachment, whether it is shallow or whether it is planar or it is non-planar, or the edges of the Descemet's membrane are scrolled. If it is scrolled, then it is very difficult to attach. Or they are, less than 1 millimeter. If the separation is less than 1 millimeter, then it is easier to attach. So those kind of things are there. And then you have to take a call on whether you would use air or you would use C3F8. So if your Descemet membrane detachment is superior, you can get away with air. But if it is inferior and non-planar with scrolled edges, then you have to inject gas.
SF6, yeah.
Thank you very much, Dr. Namata. Yes, Dr. Zena, yes, please.
Just a quick point, and I do think another reason it's important to do anterior segment OCT in those patients that we don't see Descemet's detachments that are sent to us and they have inferior corneal edema, think of retained lens fragment too. Yeah. So it helps to rule out that it is a Descemet's detachment and then start thinking about other things such as that.
Dr. Amal, if you have, yes, Dr. Yassin, sorry.
Dr. Muhtasib's point, that's a wonderful point. And if it's a Descemet detachment, it's usually the corneal edema is going to be early. If it's a lens fragment, it's usually going to see it later once the steroids are being weaned off and whatnot. So it's just the time frame. But if you see corneal edema a month out or so, you definitely should do a gonioscopy and make sure that there's no retained lens fragments. Dr. Namrata, I totally agree with you. If there's a scroll or there's a fold in the Descemet's, that I cannot do that in the clinic. I have to take that to that patient to the operating room, and I've been successful in unscrolling. If it is small, sometimes it just the endothelial cells actually do migrate and they just cover it. And if it is not in the visual axis, it's usually okay. But if it is, and with persistent corneal edema, you should do something about it. And you don't have to do a whole DSEC if everything fails, or a whole DMEC. Garrett Mellis showed us that like a quarter pizza pie is reasonable in these cases. So you don't need to do a whole lot. Hopefully, sometime in the next year, we will be actually potentially doing endothelial cell therapy. So that can be also another treatment, but that's too early for that.
Is there anyone to want to add in at this point? Dr. Amal, Dr. Ahmad?
Actually, I just want to add a small point that Dr. Namrata has highlighted in an excellent way. Usually, we do the rebubbling with an air, regular air, but SF6 in cases of inferior detachment or in unusual situations. So that was an important thing to be highlighted.
Thank you very much. Okay. Is there anything for something, Dr. Yahya, you want? Just I want to ask you, Dr. Yahya, if you want in few seconds, just what is the ideal way to make the wounds, either the main wound or the lateral side wounds?
For me, of course, if we can show it, but the most important is the beginning of the scratch. Usually, I tell myself, I do this and tell my residents that you need to do a scratch. Usually, it's exactly at the limbus. Even if there is some pannus, it's okay if you have some bleeding. And then proper fixation of the eye is very important, because you always have to have a controlled dissection and entry into the anterior chamber. And for those who are still starting and are afraid of doing starting to do the surgery, sometimes they are shy to go full with the full keratome. And in this case, if they don't go the full passage of the keratome, they will get a smaller wound. And then the intended one, like 2.2 or 2.4 or 2.8. So they have to see where the triangle ends. And this is what is the actual size they are going to get. And otherwise, they will get problems like Dr. Namrata have shown. So it's very important to construct the wound properly and to dissect properly to see after the scratch, then you dissect into the cornea. And one of the good signs that you are going into the right plane, that you see the reflection of the light of the microscope over the keratome. Then you can dip into the anterior, the Descemet membrane, puncturing after the proper length you want.
Thank you, Dr. Yahya. We can move to the second presentation by Dr. Yasin Daoud. If there is any comment from any of the panelists or speaker for Dr. Yasin or any questions.
Well, Dr. Muhammad, there's a few things that I need to ask Dr. Yasin related to the lens iris fixation. He didn't face any fragmentation of the suture and slipping of the lens from the iris, because that's the main complication that we are facing, and that's push us to shift for scleral fixation or to Yamani technique. And mostly now we are doing Yamani technique because of that. I do agree that sometimes iris lens fixation shows that it's an easy way to approach, and especially when we have pupil or when we need a pupilloplasty, so a combination, it will be best. But he didn't face this problem, the fragmentation and the dislocation or subluxation of the fixated lens because of the irritation of the iris.
Dr. Yasin, can we make please fast comment, because the time is running and the people, yeah, sorry, but you need a very fast. Sorry.
Short answer. Stark published on about 278 patients. I published on about a similar number, and we have showed that actually the possibility with 5 years time, there's actually no iris problems, no suture erosion. The suture erosion was because of the eyelet. Most of the time it was cutting, but we know that the sutures do erode after a while. And any suture really does erode, except of the Gore-Tex probably now that we have been using. Since the Yamani has been my favorite technique for planned fixation, but sometimes the Yamani lens is not available, the CT Lucia, which is what we use here. So the iris suturing is a great technique for a primary if something happened, if you have zonular weakness and whatnot, and you need to fixate. But I agree with you that the scleral fixation probably over the long term is better. Watch until we publish the papers about erosion of the bulbs through the conjunctiva and complications of the Yamani. No technique is perfect. Each patient is different.
Dr. Yasin, I would like just to ask him, because always, I need an answer for this. Why nobody is talking about posterior inclination of iris claw lens? And it gives very good results. It's very simple. And actually, there is just a publication, I think, this year about comparison with the different types of scleral fixation. And there is no difference in the visual outcomes of safety. So why we don't talk about it?
So a couple of things. Number one, the AAO actually published a statement last year, earlier around April, and showing that there's no superiority of any technique, including ACIOL, iris fixation, or scleral fixation. And I personally use all of them. It depends on what works in your hands. It depends on your experience and your expertise. And it depends on what patient population you're dealing with. If somebody has really thin sclera, that's not a great scleral fixation candidate, right? Number two is the iris claw in the US, we don't actually have it. So it's, we don't have FDA approval for it. In India, whenever I've gone to India, I know that they have used it. And one of the issues is they have had iris erosions. They have had decentration of the IOL. Dr. Namrata, if you want to comment on that. But here, we don't have as much experience with it.
Okay, Dr. Namrata, if you have a comment.
Yeah, we've used it in a very limited number of cases. And it's a very good lens if your iris is okay and there are no problems with the iris. But if you don't have iris, or if you have iris atrophy, or if you have iris chaffing, etc., then of course you have to look at other alternatives.
Yeah.
Dr. Zena, I think she have a comment. Yeah, please.
Yep, it'll be quick. We also published comparing iris sutured ACIOLs and scleral fixation from 10 years of experience at Baylor. This was before the Yamani technique, and again, same visual outcomes. And if you look at all the studies, I think a large part should be surgeon comfort. And I agree, every single procedure has an issue. The Yamani is a 2-point fixation. We're looking at tilt right now and induced astigmatism. It's my go-to technique, but it's not perfect. Our iris sutured patients had higher CME than the rest of it, even though the one with the publication with PKP showed decreased compared to scleral sutured. So I just think there's so many confounding variables that we don't have a really good study, and we still don't have long-term on the Yamani. I mean, it's a very recent procedure in comparison to all these others. But again, I think it's surgeon comfort, learning the different techniques, and then understanding what potential complications there are.
Dr. Amal, please, if you have any comments, so we can move to the next.
So for the iris claw lenses, even with the most experienced surgeons, I've seen cases where, the lens is decentered, the patient is having uveitis, and I had to take out some of those lenses and replace them for Yamani. Now for the Yamani, I had an excellent experience actually of 350 cases, and we have a long follow-up over about 4 years now. So the issue of erosion of the bulbs through the conjunctiva is an issue, and it's very important, to cauterize the bulb in a wise way so that the bulb at the end is completely inside the sclera. Otherwise, it will erode. And actually, we've done a few cases in the pediatric age group, ages 6, 7, and 8. And in those specific ages, I always worry about, the patient rubbing his eye. And so we did a small modification where we place a suture over the bulb after having it, inside the sclera to avoid the erosion. So I had experience with all types of, iris sutured IOLs and the scleral fixated with Hoffman pockets. My standard technique now is the Yamani, but, there is no perfect way to fixate the lens to the sclera in the absence of capsular support.
I think we are agreed that it is, according to your experience, you can stick to one method that you feel it's better, and I think it will give you a better maybe result instead of having one instead of other ones. So everyone have, let's say, advantage and disadvantage of these techniques. We can move to the third presentation, which is by Dr. Zena about the anterior capsule. I think this is one of the most important things that everyone faces, and especially about the Argentina flag. And I want to ask especially about Dr. Yahya, because one time we discussed this point, and I want him to highlight about the tips that he can avoid to have Argentina in a very fast way, please.
Yes, thank you. It was an excellent presentation by Dr. Zena. It really very addressed everything very clearly. But I just want to highlight one point important in this. She said, prevention of complication is more important than managing, because you will avoid the complication. In my opinion, one of the things that help you to prevent complications and manage complications, regardless of what is the complication, is high magnification. If you train in high magnification, you see and know how each tissue behaves, so you can avoid the complication. Second, if you are trained in high magnification, you can see the complication happening, not by indirect clues that the complication happened. Like think posterior capsule opened, you say the anterior chamber is deep or the phaco is not working. This is secondary effect. The better training, you see the complication happening, so you can manage it early, so you have better results. As regards and then also to have rules to avoid having complications in the anterior capsulorex in every step of the surgery. Lastly, about the avoiding Argentinian flag sign in intumescent cataract, I agree with that. Deflation is very important, but again, it is about the rules. the rule of good capsular access is that you are controlling the tearing in the capsule. And in the intumescent cataract, you have the anterior chamber pressure on the anterior capsule and vitreous pressure and the pressure inside the bag. So you have to convert to equalize this by doing my trick is doing the incision like Zaina did, but once you do the incision, I curve it. So if there is gush of fluid, it will tear the anterior capsule to the direction I want. Then I aspirate and then inject viscoelastic, continue my rexes, and I can repeat aspiration as I go along. Whenever I feel there is a pressure gradient that will lead my tear to the equator.
Thank you very much, Dr. Yahya, about this. Is there any comment or question to Dr. Zaina from anyone from the panelists, please?
Dr. Muhammad, can I say one thing?
Yes, please.
Yeah, one of the things I've noticed also in training residents and fellows while doing phaco is sometimes they do not fill the anterior chamber evenly. And if you get a tilt of the lens iris diaphragm, you tend to lose the anterior capsular rexus. So it's very important to train your residents to fill the anterior chamber evenly. So, so the whole thing is in the same level. Thank you.
Thank you, Doctor. Is there any comment from any our okay, we can move. So, Dr. Zaina, you have done a great job. There is no question for you. Now let's move to our Dr. Ahmed Al-Barqi. I think Dr. Ahmed Al-Barqi is with us and he is already asleep, but he can answer if there is any questions.
So I will start.
No, but I'm still awake, boss. Still awake.
Still awake. Very nice.
Yeah.
It's just quiet.
It's 11:15 now, but it's okay.
Yeah.
Just Ahmed start to be very quiet. That's why you cannot hear him, or you cannot hear anything.
Okay.
From. Anyway,
can we go as fast as possible, please? If you don't mind.
So two questions for Muhammad Barqi. The important thing is that you mentioned clearly and very nicely and in a steps the anterior vitrectomy and posterior vitrectomy, and let us say it in this way, anterior and posterior vitrectomy for anterior segment surgeon. But the question, when the anterior segment surgeon need to do anterior vitrectomy in a capsular rupture, when he need or when that surgeon need to do anterior vitrectomy and when he should decide to do posterior vitrectomy.
Sorry, I didn't. What do you mean by posterior vitrectomy?
Okay,
you mean the
anterior vitrectomy means the problem, Dr. Muhammad.
Can I clarify? Sorry?
You mean, Dr. Safwan, you mean the party planner, right? Not posterior vitrectomy.
No, Ahmed, he means, if you allow me, can I explain? Okay, now I am an anterior segment and I don't know to do posterior vitrectomy. So there is a time I can do an anterior vitrectomy when I can decide to do an anterior vitrectomy. And if there is something happen, then I have to close and send it to a posterior vitrectomy. Is that your question?
No, Dr. Muhammad Al-Amri, this is not the way. The issues is that in this way, if you allow me.
Okay, can you give it in a direct way, Dr. Safwan, please, so we can understand you.
I'm giving it.
I believe it's my mistake that I didn't pick up you, Dr. Safwan. Sorry. So you have to rephrase it again. Sorry, that's my mistake. I didn't get it. Sorry.
The surgeon have a rupture posterior capsule, and that rupture definitely in different way, and that surgeon he need to decide using the cutter through the corneal incision or do it posteriorly. That's the important point that we need to discuss it for all our residents, because that will change our result. In other way, we need to preserve the posterior capsule or we need to decide that we lost it.
Okay, so I think it depends on the size of the capsular tear. If you have a big capsular tear, you lost all the capsule. For example, if you rupture the capsule using the phaco probe, for example, I think you will have insufficient and big rupture posterior capsule, and then you have a lot of vitreous coming in the anterior chamber. For me, if you want to decide to do the anterior vitrectomy through the paracentesis versus the parsa plana, as I mentioned in my talk, the most efficient way is to do it through the parsa plana. It's more anatomically, and you're calling the vitreous back to the normal position and also avoid traction, and you will avoid a lot of sweeping in the anterior chamber, because the vitreous even is attached to the wound. If you cut it from posteriorly, you are assured that you cut all the adhesion. But in case, the most important point is you have to remove all the vitreous inside the EC. This is the job of the anterior segment surgeon. I think all anterior segment surgeon can do anterior vitrectomy and prepare everything. In case of you have dropped the nucleus, the scenario is different for sure. You have to clear the vitreous and hand over to anterior VR surgeon. I hope I answer your questions.
Yeah, when we need to reduce or prevent enlarging a small tear in the posterior capsule, we need to go posteriorly, Dr. Ahmed. When we need to clean the anterior chamber from the vitreous totally, yes, that's the way we can go. Because if you will go a small tear, you will enlarge it and you will lose the posterior capsule. This is my opinion. And this is the approach that I'm going through to do it. So when I have a small tear and I need to preserve it, I will go posteriorly and I took the vitreous from that hole and preserve it. And if there is any remnant of the posterior capsule, I can trim it and then I can implant my lens in the posterior capsule.
I agree with you. Usually, Dr. Safwan, yes, I agree with you. But usually, if you have a small tear in the posterior capsule, what I've seen with most surgeons doing, usually if you have a small central posterior capsular tear, the amount of vitreous is not prolapsed a lot. So most of them, they inject a heavy viscoelastic in this hole, pushing the vitreous posteriorly, and you check for any vitreous there. If you cannot find any vitreous there, so you can continue the surgery. You don't need to do vitrectomy, because if there is no vitreous prolapse, there is no vitrectomy. I mean,
we are talking about vitreous prolapse, Ahmed.
Not
there is a
not
full vitreous prolapse, but through a small posterior
Can
capsule.
we move to a next point, if you allow me, because also the time is. Is there any comments about this one from Dr. Saad, because you are a veterinarian? Yes, very fast, Dr. Saad.
Yeah, sure. I just think everybody should stick to his own subspecialty. I would certainly prefer the anterior segment.
But we are an anterior segment, we want to go posterior. What do you say?
No. Trust me, you don't want to do that. I think, you want to clear your anterior segment, put your eye well. If you think there is good capsular support, and send the patient. I totally agree with Dr. Albarti. You shouldn't fish for the pieces. You shouldn't try to do a vitrectomy. I think it's very safe to allow the posterior segment surgeon to do that, because putting a single pars plana incision is not going to do the trick. Thank you very much.
Okay, is there any comments or about this issue about Dr. Ahmed from Dr. Zaina, please?
Go ahead,
Zaina. First of all, I thought that was a phenomenal talk, Dr. Ahmed. I'm a firm believer, which a lot of anterior segments aren't comfortable doing pars plana. So I really love doing pars plana anterior vitrectomy. But the way I view it, and I felt that your PowerPoint was really kind of spoke to it, is that at some parts of the procedure, I do through the limbus. So I remove some of the vitreous. I go back and forth. And then sometimes I'll go through the pars plana to bring down the vitreous. So I don't really see it as one versus the other. It's just kind of a different incision that gives me more access. And again, I am not a vitreoretinal surgeon. And I agree with Dr. Wahib that I don't go fishing for things, and I know my limitations, right? It's not really trying to get, it's basically to clear out the anterior segment so I can put a secondary IOL. That's really my goal, and then leave everything else for retina. One really quick point. I do just a small limited perotomy, an MVR blade, and then I suture my, again, pars plana incision. I'm not comfortable doing trocars. I'm not comfortable doing these, again, leakless incisions. Is that okay for an anterior segment surgeon? Any points or recommendations otherwise?
Dr. Yassin?
You make a great point. I think pars plana vitrectomy is protective to the cornea. I think it's not incarcerating things. It's a lot cleaner. It's dynamic where the fluid is coming in. You can use your anterior vitrector through the pars plana. I believe in this day and age, every anterior segment surgeon should be able to do limited pars plana vitrectomy so that you at least clean the back. I start with pars plana, then I'll actually go to the anterior to see if there's any residual vitreous. But otherwise, it's my go-to technique. It's a lot cleaner, especially if you're going to put a secondary IOL and whatnot. You know that even if you clean from the front, the sideways is still not there. So pars plana is the way to go. Please don't touch the median in the process.
I'll just make a comment, very short comment about this. I agree with you. It's more trendy now, doing the trocars and the pars plana. Sure, it's a good idea, but this does not negate that you can do a perfect anterior vitrectomy through the limbus. And the whole idea is how you do it. And now even with the 23 gauge, it's much better. And the trick is, as you said, the fear that you are going to pull on more vitreous. And this is the fear of the limbal approach. And the trick to avoid this that we have used long time ago when in pediatric cataract surgery, that you dip with your vitrector in through the opening into the vitreous, so you create a cavity that pulls down the vitreous. So when doing the vitrectomy, you will not get more vitreous. And this is a clean, very clean way. And you can check any vitreous strength in the anterior chamber using a fine spatula from paracentesis and sweeping from the periphery to the center. And I'm saying this because not every doctor, not every hospital will have the trocars. And we should not just tell people not to do it. If they do it in the right way, the results is, in my opinion, as good as the limbal. I do both.
Thank you, Dr. Yahya. Is there any comments, from Dr. Amal or Dr. Imad? Okay, we can go to the last presentation. I think the Dr. Saad about post-operative endophthalmitis. Is there any question or comment to Dr. Saad?
Dr. Mohammed, one comment to Dr. Saad, and is that did you try any combination of antibiotic other than vancomycin and ceftazidime? Definitely, you were lucky that in your case the bacteria was sensitive to vancomycin and ceftazidime when you did it as a vitrectomy early without waiting for the culture and drug sensitivity.
Dr. Saad.
Okay, you give the vanco for the gram-positive and the ceftaz or the amikacin for the gram-negative, and you do that empirically before knowing the results. Once you get any results, and we know that from literature, only 50% of these cases will grow bacteria, then you can treat accordingly because they do culture and sensitivity. But routinely, we use these two antibiotics.
Any other question?
Yes, I have a comment and a question. One comment is that in the case you showed, Doctor, of course, you are an excellent surgeon and excellent presentation, excellent cases presented. But I don't consider that you have done an early vitrectomy. This is very late vitrectomy. The vision was dropped to light perception. And actually, this is the indication of the vitrectomy endophthalmitis study in the 1990s. And I don't agree with the COVID. This is an emergency. Our hospital will not requires culture, but except for emergency cases. You take care because you postpone surgery for 1 day already. It was late. In my opinion, as you said, pain is not the major thing. But immediately, if I see the patient with any reaction, I'm suspecting that it is endophthalmitis, vitrectomy, as you said, is the solution. Second, the prevention is important, and now we use intracapsular antibiotic, which is very important to inject it in the capsular bag, the antibiotic. Third, you did not mention, which is I think because of the time, about propionibacterium infection, which is an important thing that we should all be aware of, late endophthalmitis.
Okay, can you comment very fast, Dr. Saad, about these 3 points? Then we can conclude.
I hope I understood the question well. For the COVID testing, this is the policy of the hospital. We cannot overrule it. For the P. acne endophthalmitis, this is chronic and the topic is acute. So that's why I did not mention P. acne endophthalmitis. Now, what I'm trying to say is that even if the patient vision was counting finger, I would still, think that earlier vitrectomy is the way to go.
Definitely.
The fact that the patient presented late but from the time he presented, we acted immediately. And I totally agree on the fact that time is very, very critical in these cases. And that's why we elected to inject the patient until we get the COVID test.
Thank you very much. I think we are already too late, especially for Dr. Namrata. Already is maybe around 1 o'clock in the midnight. So thank you very much for all our speakers for an excellent presentation. We hope that we cover all the points in related to phacoemulsification. I know sometimes even only one topic, it needs one webinar, but this is a general information, general, pros and cons, and we have just to cover certain point and to highlight about a very important point. I hope that we highlighted nicely by our eminent speakers, and thanks for all of you for being with us. Thanks for the our management event and for the sponsoring company for this webinar. Thank you, and we hope to see you inshallah.
Thank you all.
Good night.
Bye
Bye.
Thank you all.
Thank
Good
you.
night.
Bye.
Bye.
Take
Good
care.
night.
Bye-bye.
Bye.
Stay safe.
Bye. Thank you, Dr.
Thank
Namrata.
you.
Sorry for
Thank you.
delaying you. Sorry,
No,
we
it's
are
okay.
sorry for that.
No,
But we cannot
perfectly.
change the timing between difference between you and